A very good afternoon, everyone. So, we are back again for the second session, and I hope you've revised the yesterday's session and keep those notes and keep revising them, right? So, I always say revision is the key factor to give you an edge, right? You keep reinforcing, only then you can remember anything. And as far as today's lecture is concerned, I've already shared the PDF of this lecture on my Telegram group. And after the lecture, I will share it with the annotations on that group itself, right? And you all know the group name is iOrtho. All right. Okay. So before we begin, let's see what is there for Unacademy to offer to us. Well, Unacademy, as I told you, is pleased to give all of us a flat 25% off and with free physical notes and access to the PG Vitals. The most important thing is it is free extension up to 12 months, which is really, really good. Then obviously, if you are one of those who go and crack, you will be in one of these pictures in my next sessions. And maybe you don't remember us, but we will always remember you in our lectures, and we will keep congratulating. And then again, for FMG preparations, you can have a 3-month subscription, and for next and NEET PG, you can avail a 9 months live subscription. For all additional benefits, you can use the code Bhumika, right? With all this, Campylobacter, Prakhar Tiwari, good afternoon. And there are people joining in. With all this, I think let's start with the session for today. So we had missed 2 to 3 slides yesterday, so I will be continuing from them. So here on your screens, identify this image. Well, as I always tell you, I will not give you options because I don't want you to waste time on the options. Once, if you know it, your eye should just catch immediately which is that option so that you don't waste your time, you don't waste your energy reading the options unnecessarily. All right. So, okay, tell me, what is it? I need to know the name of the appearance, not the diagnosis. Everyone has come down to pseudo exfoliation. Pseudo exfoliation, what is the appearance called? What is it called? Tell me. This appearance is called bull's eye pattern. So no, Shipra, it's not breadcrumb, it's bullseye pattern. So what do we mean by bullseye pattern? So whenever I say bullseye pattern, you are absolutely correct. The diagnosis is pseudo exfoliative, but what is happening here is, if you see there's a collection of the material here in the center, then there's an area which is free of the deposited material, and then again the material is present in the periphery. But if you see this area which is clear of the deposits, why is it so? It is nothing special, but that once the iris rubs here, it's because of the constant rubbing of the iris that this area becomes pigment free. It becomes pigment free because of iris rubbing, right? So if you see carefully, I will zoom it. There is pigmentation, there is no deposits, and again there are deposits. So now this pattern is called as bull's eye pattern. And what is the diagnosis? Now I come down to it. What you have answered in there, the diagnosis here is pseudo exfoliation or pseudo exfoliative syndrome. Absolutely right. So it is called a pseudo exfoliative syndrome. So what is pseudo exfoliative syndrome? Please remember, pseudo exfoliative, whenever we talk of, it is the most common cause of secondary open angle glaucoma. It is the most common cause of secondary open angle glaucoma, and also it is the most common cause for acquired zonular insufficiency and lens subluxation. All right. So whenever I talk of pseudo exfoliation, please remember bullseye pattern. It is the most common cause of secondary open angle glaucoma and most common cause of acquired zonular insufficiency with lens subluxation. Will you remember this now? So please write it down in the chat box. What is this appearance called? Now you should never forget it. It is bullseye pattern. Write it down in the chat box and I'm waiting for you. It is bull's eye pattern. So let's see. Whenever we talk of pseudo exfoliation, I told you this is the which pattern. I want it in the chat box, please. Which pattern is this? This is bullseye pattern. Very good. Very nice. Now you will never forget. So classically, pseudo exfoliation is classically age related. It is seen in people more than 70 years of age. And what do you get it? Here you have a gray dandruff-like material. Gray dandruff-like material which is deposited on all these structures. No differentiation. Going from anterior to posterior, you will have it on the cornea, in the angle more predominantly inferiorly, on the pupillary margin, the classical picture that I have showed you, on the lens epithelium and anterior lens capsule, on the zonules, ciliary processes, and anterior vitreous. So you name it, you go it from anterior to posterior, everything is involved. So all you have to remember is there are these gray dandruff-like pseudo exfoliation. They are these deposits which are deposited, these are material which is deposited on these structures. More than 70, most common cause of secondary open angle glaucoma and most common cause of acquired zonular insufficiency. The question here is, the catch here is, what are the extraocular sites where you get to see this, right? So bullseye pattern, you know, in the eye. And what are the extraocular sites? Please note down. It is skin, lungs, heart, and liver. All right. So all these extraocular sites will also show you the deposits. It is skin, lungs, heart, and liver. And then what are the important ocular features? Sampiolaces line. So Sampiolaces line is one important plus. Please remember, it is not pathognomic. It is not something which is so specific to pseudo exfoliation. So Sampiolaces line is a finding but not pathognomic, right? So what is Sampiolaces line? Tell me, what is Sampiolaces line? It is pigment deposition which is anterior to the Schwall base line. So pigment deposition anterior to the Schwall base line is called as Sampiolaces line. You will have a poorly dilating pupil because you have these deposits around the pupil itself and raised intraocular pressure. And what kind of a glaucoma? I told you what kind of a glaucoma will it cause. It will cause secondary open angle glaucoma, and it is the most common cause. Right? So why secondary open angle? Because all these deposits go into the angle and hence they increase the impedance to outflow. Right? So this is pseudo exfoliative glaucoma bullseye pattern. All right? Okay. So now identify these structures. So I will name them as A, B, and C. Tell me, what is A? What is A? Anybody wants to attempt? What is A? A is easy. So what you see, I will just show you. What you see are the pigment deposition in a vertical spindle-like manner. You see here? This is A. What is B? I will just try to mark these. You try and focus on this part. And what is C? Try and focus on this area. All right. So A, C, you say is Washer's ring. Washer's ring is B. No, I will tell you. So A is, what is A? A is Krukenberg spindle. What do we mean by that? These are the pigment depositions on the cornea in a vertical spindle-like manner. So Washer's ring, when you get, that would be in the form of a round structure on the anterior lens surface, but in the form of the pupillary, that's an imprint of the pupil. So it would be round, but this is vertical. So this is Krokenberg spindle. You're right, it is pigmentary glaucoma. Let's see, what is B? Now, what you see here is these are mid-peripheral. This is the pupillary margin. Here is the iris. So this is mid-peripheral transillumination defects. And which out of the three is the pathognomic sign? You have to tell me when we finish. So what is this? This is mid-peripheral transillumination defects. Right? And what is C? And when we talk of C, I told you, you look here. So basically what you have is you have the deposits of the pigment on the lens equator and the anterior lens surface near the equator. So what is this? What is this called? This is called as Zentmere stripe or Zentmere ring, or it is called as Scheisse stripe or Scheisse ring. Do you get that? So this is Zentmere stripe or Zentmere ring, also called as Scheisse stripe or Scheisse ring, when you have the deposits at the equator of the lens, right? So what is the diagnosis here? The diagnosis here is, so what is the diagnosis? The diagnosis is pigment dispersion syndrome. It is PDS or pigment dispersion syndrome. Now tell me, out of these three, A, B and C, what is the pathognomic sign? What is the pathognomic sign of pigment dispersion syndrome? Yes, the glaucoma that you get here is the pigmentary glaucoma. What you get here is pigmentary glaucoma, absolutely. And what is the, which is the pathognomic sign? Anyone wants to? No, it is this. This is the pathognomic sign of pigment dispersion syndrome. All right. And whenever I talk of pigment dispersion syndrome, what are the things that should strike in your mind? So whenever we talk of pigment dispersion syndrome, the first thing that should strike in your mind is what is the configuration of the iris in pigment dispersion syndrome? Tell me. Is concave iris configuration, giving you a reverse pupillary block. Giving you a reverse pupillary block. By that we mean, you all know that here the iris is concave like this, which comes in contact with the anterior surface of the lens. So when you have a pupillary block, what you have is you have an excavation of the peripheral iris, which is called as iris bombay. But here you have concave iris configuration, which is not going up but is actually dipping down. So that is called as a reverse pupillary block. And what are the other things? You should know that pigment dispersion syndrome classically seen in young myopic males. These are the things that you should never forget. It is called as pigmentary glaucoma. This is called as pigmentary glaucoma, which classically increases on exercise and on pupillary dilation. And why it increases on these two? Because there is increased pigment release. Since there is pigment release, since there is constant rubbing, hence you have mid-peripheral transillumination defects. So ab to nahi bhulega. So if you know the concave iris configuration, you know it results in reverse pupillary block, and hence the pathognomic sign that I told you is mid-peripheral transillumination defects, because now because of this concave and coming in contact with the anterior surface of the lens, there is constant rubbing at the mid-periphery, hence resulting in transillumination defects. All right, now no confusion. So now you know, just see the pictures once again. This is Krukenberg spindle, where you have this pigment deposition in a vertical spindle manner. Here you have all these mid-peripheral trans-illumination defects, and here you have the pigments on the lens equator, which is called as Zentmeyer stripe or Zentmeyer ring, or is called as Scheisse stripe. All right, okay. So identify this. What is this? Again, I will label it as A, B, and C. All the three are the same structures. If you can just tell me what is B. Okay, you tell me what is B. What are you seeing here? Anybody wants to attempt? There is a hint here which is given. So this is the chiasm. If you want to take a hint, this is the chiasm, and this is here the pituitary gland with its stalk. So now tell me what is seen in B. Well, what is seen in B is this is the chiasm and this is the stalk, as I told you, and this is sella. So what is the normal position? What is the normal position of optic chiasm? You know, optic nerves come inclined in 45 degree. They cross, they run posteriorly over the cavernous sinus and they cross above. So what is the normal position of optic chiasm? So if you try to see here, the hint was here. So if you try to see these, this is the chiasm which is present, and just below this round structure is sella. So my question here is, what is the normal position of chiasm in response to in connection to the sella? So what is the normal position in connection to sella? There is no SOL. I just mean to show you it is a normal sella, and this is the chiasm which is placed above the sella. So if you see the section here, so it is placed above the sella. So the normal position of the chiasm is 10 millimeters. The normal position is, it is placed approximately 10 millimeter above. It is directly above the sella. So that is the normal position. And this is seen in approximately 85% of the population. So what happens to the rest 15%? So when this optic chiasm is placed in a rostral position, so when this chiasm, as is here, is placed in the rostral position, see here, and compare, this is right above the sella, and here it is a little in front. So once it is in the rostral position, it is closer to tuberculum sella, and this is called as prefixed chiasm. All right. Similarly, if you see it here, this is the sella and chiasm is placed in a caudal position. So once this is placed in a caudal position, it is closer to dorsum sella. And now it is called as, see, this is the chiasm. If you see in this image, this is the chiasm and here is the sella. And this is called as post fixed chiasm. Right? So now you get it. So the normal position is right above the sella, around 10 millimeter above the sella, and that is seen in 85% of the people. So once it is in rostral position, it is closer to tuberculum sellae. It is called as prefixed chiasm. It is called as prefixed chiasm. And once it is in the caudal position, it is closer to dorsum sella, and it is called as postfixed chiasm. And why does this position vary? The answer lies in the yesterday's session because of the variability in the length of the optic nerve. Hence, you can have it in the rostral or right where it is, or in the caudal position, the chiasm. So do you get that? So this is the position of the chiasm in relation to the sella. It can be prefixed, it can be normal, or it can be post-fixed. Okay? All right. So let's see further. Okay, now you have to tell me, who am I? So what do you see in this? What do you see in this image? It's a uh, very interesting image. So this is image A, this is image B, and this is image C. Okay, tell me, what can you see here? Anybody wants to attempt? If not the diagnosis, just tell me, what do you see in image A, what is seen in image B, and what in image C? Absolutely, Mithu. This is AD's pupil, but what do you see? So if you see here, this is the light which is being shown to both the eyes, right? So this is the right eye and this is the left eye. So what you get to see is, in this image, jumping to the diagnosis. Don't jump to the diagnosis. If you know what is shown, you know the diagnosis. So if you see in this images, to the light reflex. So basically, once the light is being shown here, this pupil constricts, right? But since there is no direct coming in the left eye, so the light reflex is, direct light reflex is absent in the left eye, but iska consensual is seen in the right eye. So what you have is, left eye, once the light is shown, there is absence of direct pupillary reflex. That is absent. Now we come to point 2. Image B, if you go, so what is this? This is a near target. What is this shown here? This is a near target which is shown. So when the patient tries to look at the near image, what is happening is, see, there is constriction of the pupil here, which is expected, and compare the pupil here and here. Do you see any difference? Yes. What you see is, the pupil has constricted here in comparison to this. So if you see the near reflex, so what you have is, the near reflex is present in both, right? So when you show the near object, there is constriction here also and here also. So near reflex is present. Now you remove the target and you ask the patient to look at distance. So what is the normal response? Once you look at distance from nearest, the pupil would dilate. But here, compare the dilation of the two eyes. The pupils should dilate equally. But if you look here, this is more dilated as compared to the left one. So if you look here, this is more dilated as compared to the left one. There is asymmetry in dilation. So that means on refixation, on fixation to a distant target, the redilatation of the pupil is slow. So what are we dealing with? What are we dealing with? Let's write down. There is the light reflex, the direct light reflex absent, near reflex is present, and there is slow redilation on seeing distant. So what does this thing mean? This means the pupil is tonic pupil. So what are we dealing with? What does this mean? This means there is a light near dissociation. So when we're talking of a light near dissociation, what are we talking about? We're talking about a tonic pupil. What are we talking about? We are talking about AD's tonic pupil. Now, do you get it? What is the right way to come down to it? This is the right way to come down to it. Yes, AD's tonic pupil or Homie's AD's pupil. That's basically Homie's AD syndrome, which is associated with altered uh, knee reflex, knee jerks also, right? So let's see. So what do we need to learn here is now what is AD's tonic pupil. So when we talk of AD's tonic pupil, what are the things that we should know? The AD's tonic pupil, whenever we learn, whenever we talk, so we need to know it has a light near dissociation. You just saw one thing, you just saw there's a light near dissociation. The other thing is, where is the lesion? The lesion is at the level of ciliary ganglion, and it's a post-ganglionic lesion. It's a post-ganglionic lesion. The third important thing that you should remember with this is denervation supersensitivity. To answer this now. To what? Denervation cholinergic supersensitivity. To tell me. It is sensitive to what? Anybody wants to attempt? Denervation cholinergic supersensitivity to 0.1% pilocarpine. That means the pupil constricts to 0.1% pilocarpine also. So hence, which is not a normal response, right? So there's a denervation supersensitivity. So the three things that you should always remember whenever I say AD's tonic pupil is there's a light near dissociation, which we just saw. And where is the lesion? The lesion is at the level of the ciliary ganglion, which is a post-ganglionic lesion, and there is a denervation cholinergic supersensitivity. Hence, it reacts to 0.1% of pilocarpine. Is that okay? So what is the pupil here? Is it a dilated pupil or is it a smaller pupil? So whenever we talk of an anisocoria here, which eye is affected? The one with the larger pupil or the one with the smaller pupil? So which eye is affected here? Basically, denervation supersensitivity means denervation cholinergic supersensitivity, that because of the innervational issues, to simplify it, because of the innervational problem, the problem is at the level of the innervation, there is supersensitivity to to the cholinergic system, right? So even if you give miotic, which is 0.1%, which is a parasympathomimetic, if you give even 0.1%, it is so sensitive, it is so so sensitive to this concentration also, that the pupil constricts. For example, you're meeting your parents daily, right? You do not have emotional bouts, but you go to US, you come back to India after 3 years. So even at the sight of your parents, you will start watering, you will start crying. So that is the super sensitivity because of the distance, right? So something which is there is an issue with the innervation, there is the problem with the ciliary ganglion, with the postganglionic nervous system, which is not letting it react to a normal concentration, even a lesser, even a diluted pilocarpine, as diluted as 0.1%, will bring in a response which is not normally seen. Okay, you get that? Is that all right, Dr. Pihu? Now is that clear? All right. So now here you're right. The affected pupil is actually the larger sized pupil. Larger pupil is the affected pupil. So this is AD's tonic pupil. All right. Okay. So let's move on to the next one. So a patient presents in an unconscious state with history of intake of some alcohol and has a characteristic odor. This is very easy. What are we suspecting? This is something which is easy. Characteristic odor, alcohol, some alcohol. What are we suspecting? So what are we suspecting? Anybody wants to attempt? Okay, you also write, I will also write. Methanol poisoning. Absolutely, Adnan Ali Ansari. Very good. What are we suspecting? We are suspecting methanol or methyl alcohol poisoning. Now tell me, for all the effects that you get in methyl alcohol poisoning is because of which compound? What is responsible for causing the effects of methanol poisoning? What is responsible for causing all these effects? Formic acid. Absolutely. It is formic acid or formaldehyde. I'm coming to it, Pihu. I'll just explain it in a matter of few seconds. Just let me come down this, all right? So basically what happens is the methanol or the methyl alcohol with the help of an enzyme results in the formation of formaldehyde or formic acid. And what is responsible for the characteristic odor? It is formaldehyde which is responsible for the characteristic odor. So what brings the characteristic odor in this patient? That is formaldehyde. So now I said there is an enzyme which is responsible for converting methyl alcohol to formic acid or formaldehyde, which results in blindness, or in this kind of blindness as a permanent blindness. So in the treatment, which two what two chemicals are considered in the treatment? There is a treatment, there's a long list. You will give a gastric lavage, you will do peritoneal dialysis, you will give these two. Tell me two compounds which are considered in the treatment of methyl alcohol. So which two alcohol is given? Which alcohol is given? So two things in the treatment which you should remember, two chemical structures, two chemical names, two names of the chemicals which are considered in the treatment of methyl alcohol is ethyl alcohol. Very good. And what is the second one? Very nice. Or ethanol. But which is the second one? Right? So these two you should remember. Now I come down to the question which I said, that methanol is converted to formic acid or formaldehyde with the help of an enzyme. So why are we giving ethanol? Why are we giving ethyl alcohol? Because ethyl alcohol competes with methyl alcohol for that enzyme. Tell me the name of the enzyme. So what is the enzyme that is responsible? This and this fight for which enzyme? The name of the enzyme is, tell me, the name of the enzyme is alcohol Very good, Neha Kiran. Very good. Right? So, this is in short all about methanol poisoning. It is so easy. What you have is when the patient has when the patient has methyl alcohol or methanol poisoning, which can be because of the drinking of these wood spirit, or with the from for the methylated spirit or wood alcohol, or it can be from the inhalation of the fumes in patients working in these industries, or because of the liniments, it can be absorbed from the skin. So this enzyme alcohol dehydrogenase, it acts on the methanol to form formic acid or formaldehyde, which is the agent responsible for causing all the signs and symptoms. And in the treatment for the, you have to compete with this enzyme alcohol dehydrogenase and not let it act on methanol, but the ethanol competes with methanol for this enzyme, and this enzyme is alcohol dehydrogenase. And the second compound that is used in the treatment is sodium bicarbonate. right? So these two can be used. Then you can do gastric lavage and rest is all the list, right? Okay, so tell me the causative agent in tobacco smoking and cigars. So what is the causative agent in tobacco smoking and cigars? Is here the agent is formic acid, formaldehyde. And in when we consider cigar smoking, tobacco smoking, the agent is it's not nicotine. The one which is responsible for causing the symptoms and toxic neuropathy is cyanide. So, nicotine is the compound which is present in the tobacco, but what is the compound which is formed in the body resulting in all the signs and symptoms and toxic neuropathy is cyanide, right? So I'm not asking you the component of tobacco smoking or cigar. So this is my main aim to put these questions here is whenever you attempt a question, please read each word carefully. They all know we are falling short of time, so we are all in a hurry to finish the paper. We all make a quick attempt, but these small points, the main words should be there. So my question was causative agent in tobacco smoking or cigar for causing toxic neuropathy. That is cyanide. I did not ask the agent in tobacco smoking or cigar which causes toxic neuropathy. So that would have been nicotine. So now do you get the difference between the two? This is what I mean to say. The person who has patience yet is quick is the one who leads the line. All right? Do you get that? Do you understand the difference now? All right. So next, let's come to this. So you have uh, a presentation like this. There is a lesion, toxic neuropathy. Yes, absolutely. Yes, yes. So there's a lesion. So what you have is these are the optic nerves. This is the optic chiasm, and there's a lesion like this. What will be the presentations? What would be the kind of field defects? This is a little tricky, so I will tell you this. So the field effects with this lesion can be of three types. The first, as I told you what do you call this structure? The fibers which are going here, these fibers which are going here and here. What is these fibers called? What is the name given to this kind of a structure when they loop around and go behind? What do you call it? What do you call it? You call it Wilbrand's knee, right? So now what is Wilbrand's knee? These are the inferior nasal fibers of the nerve which loop into the contralateral nerve before passing behind as optic tract. So basically this is not Mears loop. Mears loop is after the LGN. These fibers, they curve around and form the optic radiation near the temporal horn of the lateral ventricle. So that is Mears loop. This is Wilbrand's knee. So whenever there's a lesion like this, it will affect, it has three presentations depending upon the number of the fibers which are affected, right? If it completely affects, say this is right and this is left. So if it completely affects the right eye, it can do that, or it can have other presentations. So if it completely affects the right eye, there is complete loss of vision in the right eye. With left eye ke only nasal fibers which are going. So if only nasal fibers are going, so it is going to affect the temporal field. So one field defect is this. You get that? So there will be a complete loss in the right eye, and left eye only the temporal field is gone, because those are the nasal fibers which curve around before going into the optic tract, right? So do you get that? That is one part. The other that you can have is the same lesion can present as like this also. They can have these central fibers affected on the side of the lesion, and only the superotemporal scotoma in the contralateral eye. Why? Because classically, the inferonasal fibers actually loop around to form the Wilbrand's knee. So maybe some nasal fibers are affected here also. Then you give the entire temporal is affected. But only if the classical described Willebrand's knee is affected, which is the inferonasal fibers, they will give you a superotemporal defect. So you can have this kind of a field defect also. The third kind of field defect that can happen is, okay, we'll have it like this. The third that can happen is completely no effect on the left side, but just the nasal fibers of the right side are affected. So that all these three depend, and the left eye, okay, I will just move, and the left eye stays normal. So all these depend, the presentation depends upon the size and the compression it is causing on the nerve. So all these occur when the compression is at the junction of optic nerve with optic chiasm, right? So now you get that. So you can have either the complete right nerve is gone and so complete blindness in the right eye with only the nasal fibers going, only the temporal hemianopia. That is one. The other that you can have is only some central fibers, only some macular fibers are affected in the right eye where there is lesion, and left only the inferonasal fibers of the Willebrand's knee are affected, giving it a superotemporal scotoma. So the special name given to this kind of a picture is called as junctional scotoma. All the three are the presentations of the lesions occurring at the junction of the optic nerve with optic chiasm, but depending on what is the size of the lesion, how much nerve is affected, how much compression is there, you can have these three presentations. And last is when you just have the nasal fibers of the affected side of the lesion which is gone, resulting in a temporal hemianopia, and the other eye being completely normal is called as, this is called as junctional scotoma of trachea, right? So now these are the three kind of presentations that you can have. Do you get that? So here this eye will be completely normal. The contralateral is completely normal. Only temporal hemianopia of the affected side. So these are the three kind of presentations that can occur with this kind of a lesion at the junction of the optic nerve with optic chiasm, right? First presentation नहीं समझ आया. This presentation is when the lesion is complete like this. Yeah, when the compression is so much that the lesion is completely compressing the right nerve. So there is a complete scotoma in the right eye and left. I told you some nasal fibers go and turn a loop around. So when all the nasal fibers of the left eye are affected, there will be temporal hemianopia in the left eye also, right? So left eye के सारे nasal fibers affect हो सकते हैं, left eye के only inferonasal fibers affect हो सकते हैं. So when we taught Willebrand's knee, inferonasal fibers are the ones which loop around. But if there's a lesion here which is affecting this part also, a part of the optic chiasm also, there are those inferior fibers which are crossing, the nasal fibers which are crossing. So those fibers can also be affected. So just depending upon what is the type of compression, what is the amount of compression, they can have these three presentations. Everything is about junctional scotoma and junctional scotoma of trachea. Is that clear? So we move on to the next. So this is simple. What do you see? Mohit, what do you need to ask? And Dr. Pihu, I didn't get you. Second important, I didn't get the questions. If you can please write the questions completely, I will take those. So who am I? So here is a lesion here on the lid and what you get to see here. So tell me, what are you seeing in image B? History में वो ये बताएंगे that there's a lesion at the junction of the optic nerve and optic chiasm, but you will have only one out of the three presentations in the option, right? If it says only junctional scotoma, if the the option is just junctional scotoma. So this would be the kind of presentation. This one would be the kind of presentation. If the question is also asking about junctional scotoma of Treque, see, it has three presentations, but then the names are also different. So that is what you need to match. So this presentation can have all these three, but you have to match what the question says and what is the option. So that is what I mean to explain here. Okay. All right. So here you have a lesion, and what is this? Tell me, there's an asterix made here. So what structure is this? This is a pathological picture. This is not a dermoid cyst. There's a lesion in the lid. So what you get to see in the image here is a keratin pearl. And lesion in the lid, keratin pearl, what is the diagnosis? It is, what is the diagnosis? Absolutely, very good. It is squamous cell carcinoma. So these are the eyelid malignancies. So whenever we talk of an eyelid malignancy with keratin pearl, it is squamous cell carcinoma. Whenever I have eyelid malignancy like this, and on histopathology, what you get is you get a retraction artifact. You get a retraction artifact, you get characteristic palisading and oval nuclei with high nuclear to cytoplasmic ratio and an ulcer like this. What are we talking about? Very good. We're talking about basal cell carcinoma. Now the next question comes, which is the most common eyelid malignancy. The most common eyelid malignancy is basal cell carcinoma. You say, all right. What is the most common subtype of BCC? What is the most common subtype of BCC, what is the answer? It is nodular basal cell carcinoma. And what is the location? You have to tell 1 and 2. Most common location for BCC is? Most common location for BCC is Now, do you get why I asked you this? So, medial canthus 48%, lower eyelid 47%. So, if both of these are there in the option, you have medial canthus as well as lower eyelid. So, what would be the correct answer? The correct answer is medial canthus. But if only one is present in the entire option, then you have to mark that also. That one only which is there, either the lower eyelid or medial canthus. But if the option contains both medial canthus, lower eyelid, upper eyelid, and lateral canthus, then the correct answer would be medial canthus. And what is the fancy name of this ulcer? What is the fancy name of this ulcer? This is called as rodent ulcer. Why is it called as rodent ulcer? Because it is locally invasive. Because it is locally invasive. Now, one important catch point here which I need to tell you is, I have asked you most common eyelid malignancy. Now, here there's a controversy. Most common eyelid malignancy is basal cell carcinoma in Western population. In Western population. But when we talk of the most common eyelid malignancy in the Indian population, when I talk of in the Indian population, the answer is sebaceous cell carcinoma. The answer is sebaceous cell carcinoma. And from what is the recurrent lesion is a very common history which you will get when you suspect a sebaceous gland carcinoma or sebaceous cell carcinoma, right? So this is the difference. Whenever we talk of a Western, this is actually This is a controversy. This is a point of controversy. But yes, most common eyelid malignancy in Western population is BCC, but in the Indian population is sebaceous. Are we clear with this now? All right. Okay. So moving on to the next. Identify this. What do we see here? What do we see here? What do we see here? Jaw moving to one side and jaw moving to the other side. And what is the effect on ptosis? Tell me. So what we get to see here is ptosis, right? Ptosis of the ptosis of the left side. And this ptosis, if you see, when you move the jaw to the left side, it doesn't improve much. But if you move the jaw to the right side, there's a drastic change in the ptosis. So what is this? This is called as Marcus gun jaw winking ptosis. Right? So this is called as Marcus gun jaw winking ptosis. So what happens is when you move your jaw like this, there is improvement in the ptosis. And the point to remember here is the ptosis improve on the movement to the contralateral side. Ptosis improves when the jaw moves to the contralateral side. And the last thing to remember here is the aberrant regeneration or the aberrant connection is between the levator muscle and fifth nerve. The aberrant connection, I will not call it as regeneration, but the aberrant connection is between the levator muscle and the fifth nerve. Right? So this is Marcus gun jaw winking ptosis. Opposite side movement, ptosis improves. Very good. This is a very good way of remembering. If you can write it on the chat box, you will remember it. So this is called as Marcus gun jaw winking ptosis. All right, moving on to the next one. Catch me if you can. Tell me the name of these signs. Okay, I will label them. This is A. This is B. This is C. And this is D. What is A? What is A? A is Dalrymple's sign. What is Dalrymple's sign? By Dalrymple's sign, what do we get to see here is bilateral. See, again you jump to the diagnosis. I want the name of the signs. Yes, there is eyelid retraction. So what we get is eyelid retraction. Hence, it is called as Dalrymple's sign, and this is the most common and earliest feature of thyroid eye disease. The most common and the earliest feature of thyroid eye disease is Dalrymple's sign or eyelid retraction. The second that we get is what do we see here? This is, you see the patient is trying to look down. Here it is going, but there is a lid lag. You can see the sclera in between. So this is lid lag on down gaze. And we did yesterday about an aberrant regeneration, but this is the true sign. So this is von Graff's sign. Remember, we did a pseudo von Graff's and the third nerve aberrant regeneration, right? So what is C? C is what you have mentioned right here. It is exophthalmos. When you will see it like this and you will compare the two eyes. So you see here, this is exophthalmos. And what is this? Inability to completely close the lid is legophthalmos. And what are we dealing with? So we are dealing with thyroid eye disease. And what is the classical radiographic appearance in that we get on in thyroid eye disease? The classic radiographic appearance is, please remember, everything, all the muscle is enlarged, sparing the tendons. So there is a classical sparing of the tendons. So what you get to see here is there is enlargement of the muscle. See the muscle belly. Here the muscle belly is enlarged, but there is sparing of the tendons. So what you see in yellow, I will write in yellow, but you will not be able to see. Okay, I'll write in green. There is muscle enlargement. But classically, so see here, there is muscle enlargement. But there will be sparing of the tendons. This is classically what you get in the radiographic appearance of thyroid eye disease. Is that clear? Okay. So moving on to the next, just tell me what do we see here and what is the surgical treatment? Let's quickly see. So what do we see here? You cannulate the lower canaliculus, you push in fluid and the fluid passes. So what it is? It is patent. It is patent. The second one we see, we put a cannula here, we put in the fluid, but the fluid regurgitates from the same canaliculus. So now what you can do is, you can cannulate from the above and pass and just check. If the fluid flows, then there is a lower canaliculi block, right? But if you do it from above also and it comes back, then it's a common canaliculus block, because it comes from above as well as below, because then is the common canaliculus which is blocked. So if you inject fluid and it comes back from the same punctum, then it is called as a canalicular block. That makes sense, because that same canalicula is blocked and it is not going up to the common canaliculus. But if you inject in one and it comes down from the same as well as from the other, then is the common canalicular block, right? And then the last is when you put in fluid and then it goes back, it comes out from the other puncta, but along with mucus or pus, then is what we are dealing with nasolacrimal duct obstruction. Do you get that? And what are the surgical interventions that we do when we talk of NLDO? What is the surgery that is recommended here is DCR. Simple. We all know that the surgery recommended here is DCR. But if you have a common canalicular block, as in here, you have a common canalicular block, so you have to bypass this. So you will do a canalicular DCR or a Jones tube, or you put a tube here, or you put a stent here. So basically what you do is you bypass this area of the block and you directly connect the canaliculi with the sac. So this is called as canalicular DCR. But if the canaliculi only is blocked, then what would you do? Then you don't have anything further to bypass. So what you do is you bypass this and you do a connection between the conjunctiva with the sac and into the meatus, and that is called as conjunctivo-DCR, which is famously called as CDCR. ठीक है, ये सिंपल है, अब कोई कंफ्यूजन नहीं होगा इसमें, राइट? सो व्हेन यू हैव अ एनएलडीओ ब्लॉक, व्हेन यू हैव अ ब्लॉक इन nasolacrimal duct obstruction, you will do a DCR where you will connect the sac via a bony ostium into the nasal mucosa. If you have a common canalicular block, you bypass it, join the canaliculus with the sac, bypassing the common canalicular part. So that is called as a canalicular DCR. But if the canaliculi only is blocked, then uske pehle kya pada? To conjunctiva hi pada na. So what we do is we connect the medial canthus to the sac and then further. That is called as conjunctivo DCR. ठीक है? DCR is dacrocystorhinostomy. All right. Okay. So moving on to the next, let's identify these muscles. So how do you just quickly identifying these muscles is important. Let's see. So the main point I need to show here is how do you, the confusion that I get is, ma'am, we are unable to get to know which is the nasal side and which is the temporal side. So always remember the site where you get this. Which muscle is this? This is superior oblique. So wherever you have superior oblique, that would be the nasal side. And the other is the temporal side. And what is the structure that we see here? That we can label as the trochlea. So this is the part where you have trochlea. So trochlea is that saddle from where the superior oblique passes. It becomes tendinous before passing through the trochlea. Then the tendon passes and then again fans out to insert. So this is a very easy way to identify. And always remember, obliques lie below the recti. So here what you have is superior rectus, superior oblique, and then sclera. So this would be medial rectus. So I said obliques beneath the recti. So there is sclera, this is inferior rectus, and then there is inferior oblique, right? And this is lateral rectus. So now it becomes easy to identify the muscles. So this is how you identify the muscles, right? All right. So moving on to the next, what do we get to see here? So whenever you get an image like this, lesion at the macula, please remember it is always toxoplasma. Toxoplasma caused by Toxoplasma gondii, and it has a congenital and an acquired presentation. And classical thing about Toxoplasma, two things that you should remember: it causes focal retinitis, focal necrotizing retinitis, and it has a strong predilection for macula. Right? So what you get is, this is which lesion is this? This is congenital toxo. So when we talk of congenital toxo, there is a classical punched out lesion. This is a classical punched out lesion with necrotic center. Right? But when we talk of an acquired toxo, what you have is strong vitritis. So you can see a lesion here, and what you see that this entire thing is very hazy. Why is it hazy? It is hazy because of the severe vitritis. So when you have an appearance like this, what do you call it? You call it as headlight in the fog appearance. Headlight in the fog appearance, right? So this is toxo. So whenever I say toxo, always remember it causes a focal necrotizing retinitis and it has a predilection for macula. All right. So coming to the last, what we have is, we have a child presenting to us with bilateral cataract and this kind of presentation on fundus. So what is this? What is the diagnosis? So what do you get to see in this image? In image B, this is retinitis pigmentosa. No, do you think this child with a bilateral cataract, I'm telling you, a small child, bilateral cataract, is having EZO, is having this pigmentation, is recorrect yourself. This is, now you will be able to answer correctly. This is not the age which is presenting in RP. This is not perivascular bony spicules what you get in RP. So this is salt and pepper retinopathy. So what are we dealing with? We are dealing with rubella syndrome. So now the question arises, what are the findings in rubella? So I remember it as cat, mouse, kid, go eat salt and pepper. By that I mean it is cataract, it is microspherophagia, it is keratitis, it is glaucoma, and it is salt and pepper retinopathy. Right? So now the thing is, what is the frequency of ocular manifestations? The way to remember is start from here. 1, then you go here. It is 2 and 3. So salt and pepper retinopathy, number 2 is cataract, and number 3 is glaucoma. So these 3 is the frequency of ocular manifestations, right? So what do you have? Cataract, you have salt and pepper retinopathy, you have keratitis, you have glaucoma. So that is that is congenital rubella syndrome. So last picture, and what is the diagnosis? This is very easy. All I want you to tell me this fancy name to it and what is the diagnosis. This is very easy. So what you get here, you get hemorrhages in all 4 quadrants. Hence, this is CRVO. Hence, this is CRVO. The special name to CRVO, whenever I call CRVO, is a splashed tomato appearance. Why is it a splashed tomato appearance? Because it is like there's a tomato which you throw on the wall and you see all the quadrants, everywhere there is that reddish appearance. So it is a splashed tomato appearance. And second important thing that you should remember in connection with CRVO is the glaucoma that you get here, which is a complication, is called as, what is the name of this glaucoma? It is called as 90-day glaucoma, right? So these are 2 important things of CRVO that you should remember. Then the types of CRVO, which is non-ischemic or venous stasis type, and ischemic or hemorrhagic type. And you will always have RAPD even when we are talking of ischemic type of CRVO. All right. So that is it for today. And I say, if your dreams don't scare you, they are too small. If your dreams don't awake you in the midnight, you're not dreaming right. So have big dreams and you have to work hard for them. So that is for today's session. 100-day glaucoma or 90-day glaucoma. It can be, it was initially, it was said 90-day glaucoma. So we still call it as a 90-day glaucoma because that is a time period when the process develops. That means there is CRVO, there is occlusions, there is rise in VEGF, there has to be neovascularization, and then it ultimately sets into glaucoma. So that is basically, it is a time duration, what it takes to develop glaucoma. All right. So, okay, thank you for that end code. So that is it for today. I will sign off now and we meet on 29th. I told you 29th is a special free class that I take. All right. And that's on the platform, and that is from 2:45 to 3:45, and that would be a rapid fire PYQs. I will not discuss the theory there because my aim to discuss here the rapid fire PYQs is to cover as many questions as we can. Till then, I see you on 29th. Till then, keep working, keep studying hard. I wish you all the best. And I will post this on the Telegram group soon, right? All right.